could be there in person. The challenge of travel has obviously affected you all, and we're grateful to at least have this method of connecting together. So for those of you who've not been to the US, we're located right here in the middle of Florida. Last time I went left. That was the way to get there. It was a long way, but well worth it, because we not only got to visit Australia, but the beautiful land of New Zealand, and had a great adventure with Allison there. And I'll just start, for those of you that I've not met before, my clinical background is in pediatric cardiology. When I first started in this area, we would see this picture all too often in infants with Pompe disease who had significant myocardial hypertrophy that was really the cause of early fatality in those patients. And I think you'll hear next from Dr. Kishnani, who will talk about the advent of newborn screening. It's really brought us quite a long way over a big journey. And now really we don't see this complication, at least in the US, any longer. I know that in some parts of the world, there are still infants who present in this way. And I think one of our objectives is to try to help figure out ways to manage that and solve that problem. And it's commonly, across the disease spectrum, really common to understand, important to understand that glycogen is the main cause of that hypertrophy and the effects I'm going to tell you about. And I'm going to go really to emphasize that, in IOPD, we normally wouldn't see an infant who's already dependent on a ventilator, who has that degree of cardiac hypertrophy, feeding problems, deficits in strength and musculoskeletal weakness, and speech problems. And we've learned a lot over this past 20 years working on this problem as to why glycogen within muscle cells and within neurons contributes to the weakness in Pompe. And I hope in this 30 or 40 minutes to be able to tell you what we think we can do to improve on the care and the unmet need that still exists in Pompe. Certainly early treatment to try to preserve function at this stage is quite important. And hopefully you can see this a little better. At some point, there is progression of the muscle pathology, and we have a lot of new information due to non-invasive imaging that at some stage, fat replaces muscle and makes it very hard to go in the other direction or reverse the disease. So newborn screening now and early treatment, early interventions have done a lot to prevent this irreversible disease progression. But it's somewhere in this range. There probably is reversibility and options for improved therapy across the disease spectrum. And one of the ways I'm going to emphasize, I think, that we can get the greatest outcome is by how do we get alpha glucosidase into the lysosome. But this, of course, relies on it being made within the cell as it was intended. And what I'll touch on only briefly is about the new products that enhance the ability of the enzyme to target the mannose-6-phosphate receptor and traffic through these vesicles into the late endosome, where the pH is lowered and alpha glucosidase begins to do its job of reducing glycogen. I wanted to take a moment to go through this whole process because what I'm going to focus on are the gene therapy strategies for Pompe. And one of the predominant thoughts among some of the studies is that in addition to the enzyme that is trafficked through the cell to the lysosome, some of the enzyme can leave through the mannose-6-phosphate receptor and reach the inside of the cell from the cell surface. This is the concept behind liver-directed gene therapy, which aims to use the liver to secrete alpha-glucosidase into the circulation, just like this molecule would be provided in the form of enzyme replacement therapy. One thing we know from the biology, though, is that the majority of the product that reaches the lysosome goes through this pathway. So we've been really focusing on how to optimize the delivery to the lysosome and prevent or reverse the effects on cellular metabolism. So part of understanding what causes the weakness is to realize that in addition to the muscle cells that are affected by glycogen accumulation, the nerves that communicate with those muscle cells and are responsible for coordinating contractions within muscle cells themselves have glycogen accumulation in the cell body, and their long projections end on the motor, on the muscle fiber in something called the neuromuscular junction. Those neuromuscular junctions we found are also impacted by abnormalities in the nerve cell and impact the strength in Pompe. So just considering the treatment strategies that I think will be discussed at the meeting, certainly we've had this period of time since 2006 to have some access to treatment of Myozyme and Lumizyme in Europe, and second generation ERTs have come forward with the recent approval of Nexviazyme and the near completed studies for biological licensing application of ATGAA that Amicus has developed based on this concept that the protein misfolding of the enzyme can be influenced by a chaperone therapy. And I'll touch on that in a minute. And just to reiterate what I mentioned earlier about liver-directed gene therapy, one of the predominant strategies among several studies ongoing now, and I'm going to focus on the work we're doing on muscle and nerve-directed gene therapy. So just recently, you've all heard about the approval of Nexviazyme, at least in the US, and the potential improvements in outcomes with that product. And hopefully there'll be opportunities to provide these alternative therapies throughout the world. The ATGAA molecule is unique in that it utilizes a chemistry after the protein's made to increase the number of mannose-6-phosphate residues on the protein surface that's shown here. And when combined with miglustat, the notion is that this high mannose-containing protein is quite different than even the first generation enzymes and improves targeting of the protein to muscle cells. And of course, miglustat can influence the half-life and therefore improve the stability of the protein and allow it to target muscle cells. So if we go back to the kind of compelling evidence of the very first studies done for IOPD, we see that the severe loss of function, particularly related to heart function, was reversed in the 18 patients in the trial. And compared to this historical control group, all 18 patients treated with Myozyme at 18 months of age were living. We know as those patients were considered to not just look at their status regarding heart function and their survival, if one considered their any ventilatory assistance, you see that 6 of the patients had developed a dependence on some form of assisted ventilation. And we know now that as you follow patients into longer times, this continues to decay, a ventilator-free survival. So we started to look more carefully at that question. This gives you some idea of how thick the heart was, like the MRI I showed in the beginning. And this is the principal target of early treatment now, with newborns being identified in the first week of life. We hope we never see this degree of cardiac hypertrophy, at least when there's newborn screening available. But what about respiratory function and other gaps in patient care? We know that the endpoints for clinical approval of new therapies are related to reducing the progression of disease and assessing the impact on ventilation. But there are still deficits that patients face, and there are declines in muscle function, as shown nicely in this study, which tracked over many years the increase in fat accumulation in the musculature around the spine by MRI. And now these opportunities for monitoring disease progression with imaging will tell us even more about how to prevent or reverse the deficits in Pompe. One of the efforts we undertook around the time of the last conference was to evaluate means to detect breathing function more precisely than just the pulmonary function tests. And you can see in a healthy control subject on the left, a deep breath results in a significant shortening of the diaphragm and improvement in ventilation, where the Pompe individual has to move their chest wall forward in an exaggerated fashion to try to achieve the same degree of deep breath. And the diaphragm doesn't really move as it should. And I'm going to show you an example of why we think that is the case, and make the case for why both muscle and nerve-directed gene therapy is going to be important. So, we thought ERT would be the only solution. It is an important solution, obviously, for treatment of Pompe, and we thought this was the way to go early on. And we've had some challenges along the way, and now we see here a peak of sunshine as the end of this long trail. Part of what clued us into evaluating this aspect of the disease is some of the work actually done by the group at Sanofi Genzyme to understand the neuropathology in the GAA knockout mouse that was generated by Nina Raven. These are neurons. You can see that they've accumulated glycogen, and some of them have a very abnormal appearance with an enlarged size. On the B panel, you can see by staining for periodic acid shift that similarly very enlarged neurons in the part of the spinal cord responsible for controlling the musculature. So we knew that in the mouse model that this was a finding, and we wanted to know whether how that influenced muscle function and how it was influenced by age. So Darren Falk published this paper from our group some time ago to look at over time the impact of age on muscle GAA accumulation. You see in the control there is none, and then in the later age mice there's significant glycogen accumulation. And when we look at the sciatic nerve, you can see that there is an abnormality of the nerve fiber as well. And one of the unique things about this finding that Darren had was that these special processes of the nerve that attach to muscle cells were markedly abnormal in the Pompe mice, and we've confirmed the same finding in patient samples. So how do we get treatment to the central nervous system? And this is an area that's been intense focus at the University of Florida since the late 80s, when AAV was discovered here. And so this is a delivery vehicle that we can use to incorporate the normal gene for alpha-glucosidase to replace the function of GAA deficiency. And now we're really just since a year and a half ago reached kind of a new era in AAV gene therapy, because there is now an approved therapy for systemic administration in children. And we've learned over the past 10 years that many novel serotypes of AAV can target the tissues of importance, particularly the heart and the nervous system, as well as in adults, the persistence should be lifelong in the peripheral musculature. So this is what happens when you deliver AAV into the circulation. It travels through the bloodstream, attaches to the cell surface, traffics inside to the nucleus where the DNA is deposited, and the unique configuration of AAV DNA or genomes allows it to persist within those cells for the life of the cell. And so we've engineered a variety of these viruses using different surface proteins or capsid proteins that target different tissues to help understand how to effectively treat patients with Pompe. So this is a schematic of what it looks like. The key components are that outer part, the capsid, where the protein is expressed, in this case, a promoter element that works in both neurons and muscle cells, and the native glucosidase gene or variants of it that improve its potency. And so we started this work quite some time ago now, and I think we're finally hitting a pace of discovery that is allowing this to move into the clinic at a faster rate because of developments in manufacturing and the regulatory science. So the first study was in 2011, and it was based on this finding that if we gave the gene for alpha glucosidase under these two different promoter elements, we could restore the nerve function and show that the expression of the gene was present in those cells that were deficient in both the mouse and humans. And here's another look at the work that Gary, Todd, and Darren did, that over time, between 6 months, 12 months, and 18 months, you can see there's a progressive loss of the number of muscle cells that are innervated. And this is partly contributory to the weakness, because when muscle cells do not have an impulse from the nerve, they undergo atrophy. So you see in the example in the middle where the knockout animals have abnormal motor end plates or the neuromuscular junctions, they can be restored very much like the wild type after treatment with the AAV vector. But after a time, that's not possible. So again, another value of having a newborn screening and early treatment, the intervention really needed to be completed in this 12-month time frame and not at the end stage. So just to reiterate, those neuromuscular junctions are important. We think they matter in Pompe, and that the gene therapy treatment directed at the spinal cord will impact that to try to preserve the communication between the nerve and the muscle fiber. This is an example of how that impacts the function. In this set of examples, we're looking at the part of the brain, the midbrain, that controls the musculature around the pharynx and the tongue. And the AAV vector was delivered into this part through the tongue musculature and very successfully converted all of the deficient neurons into express alpha glucosidase. And we could see the effect that had on the animals. Lots of the enzyme activity, or the protein in this case, in the tongue itself. With one of the vectors, it traveled very effectively into the hypoglossal nerve, and then that influenced the behavior of the animals that I'll show here. You can see that the animals that had the treatment with the AAV9 GAA compared to control had increased weight gain because they're better able to eat. Those muscles control the eating, swallowing behavior. So we then, having this information, turned back to a patient study, and with Barb Smith, as shown here, studied the impact of gene therapy directly into the musculature in one of the early generation of AAV products to look solely at patients who were on enzyme replacement therapy but had developed ventilator dependence. It was a study in 9 individuals that started a prehabilitation therapy prior, and remained on enzyme replacement therapy prior to receiving the gene transfer here on day 0. You see that we followed them for a year with pulmonary function tests, ventilator, off ventilator endurance, and imaging. And the result in the first cohort of patients is shown here. We see that there are, in some cases, very good responders that were able to do the prehabilitation. In those patients that were older, who had more advanced disease, did not have such a prominent response. But even though it's small in some patients, all patients had some improvement in spontaneous ventilatory endurance. So this was encouraging us to progress on to the next step. And to understand why that occurred, we recently published a study of an individual patient who was diagnosed at 35, started ventilator use, non-invasive ventilator use at 40, had become non-ambulant 38, and then became increasingly dependent on the ventilator use. We got to know this patient because of his desire to have a pacemaker therapy for the neuromuscular deficiency of the phrenic nerve. And at that time, he also had a tracheostomy. So it enabled measuring the EMGs over time from this 2-year period and then another 2-year period to establish the changes in the EMG pattern. So this was a very unique circumstance where indwelling electrodes in the diaphragm allowed us to measure, in this case, early after the placement of the electrodes, synchrony between the phrenic motor nerve in this purple graph and the breathing function in the green. And this is the left diaphragm recording, and the blue is the right diaphragm recording. And you can see that these go together. And so that's important. Over time, after 2 years or 4 years, they were no longer nicely coordinated, which represented a decline in the motor function when off the ventilator. And then when on the ventilator, you could see that with diminished effort or positive pressure in the airway, the phrenic motor output was severely diminished or absent. So it shows you how difficult it is to actually produce enough air movement if the ventilator is contributing to the feedback in the phrenic nerve. And sadly, when this individual passed away, his desire was to provide the samples from his spinal cord to examine what had happened to the motor nerves. And you can see both in the part of the brain that I had shown you in the rodent studies, as well as the cervical and thoracic spinal cord, there is a significant loss of the motor nerves that control muscle function, particularly in the respiratory area where they were almost absent. And in the diaphragm, there had been a significant loss of the muscle cells such that there were mostly fat cells replacing the diaphragm musculature, and those few muscle cells remained had glycogen in them. So we know that this progressive change is associated with a neurophysiologic cause of weakness, and that contributes to our kind of commitment to address that aspect of the disease. So aside from the local delivery therapy, we wanted to move directly towards systemic therapy. And as I mentioned, this past year was a breakthrough for this field with the approval of a treatment for spinal muscular atrophy using an osmogene and Paravec, which is known as Zolgensma. These studies were done at Nationwide Children's Hospital with Dr. Jerry Mendel, and now there have been 1,400 children who have received Zolgensma in the past year and a half. One of the things that's made it possible to treat SMA patients is that they're about 3 kilos at birth, like most babies, and it's been possible to produce enough doses in this kind of so-called sweet spot where the manufacturing is right sized to fit the patient population. The challenge we have now in adult gene therapy is how to develop the methodologies to make enough of the material to test and to make it inexpensively enough that there can be worldwide access. So we've participated in a consortium that the FDA has initiated about how to bring good ideas in gene therapy, understand the vector manufacturing constraints, and improve standards for how they're delivered and quantified. And that's currently in its second year after being organized between the NIH and the FDA. So now where do we stand in the gene therapy models that let us get back into the clinic in the systemic gene therapy arena? I showed you some mouse data. We've generated both an adult and infant form of Pompe disease in rats, and we've been able to study the naturally occurring canine model, which gives us some insight on very long follow-up after treatment. And one of the things we learned from both the canine and rat models is that we have to manage immune responses to AAV. And so I want to just touch on this, that it's the immunology has become a key aspect of the gene therapy arena, and that we care both about the antibodies that are to the vector as well as to alpha glucosidase, and that in the pediatric population, we know that over the lifespan that we may need to re-expose patients to the therapy. So what we've done is take a page out of the book of the various efforts to prevent enzyme from causing an anti-drug antibody and ERT, and use that same approach for the vector itself. And this we have found can block the immune responses to the capsid and the transgene. And this allows for repeat administration of the vector in the same way that we try to avoid anti-drug antibodies in ERT. So this work was been done by Manuela Corti, and the very first experience of this was in the first 3 CRIM-negative infants who were receiving ERT and immunomodulation, as well as the AAV gene therapy. And what we learned in that case is that those infants who were receiving this regimen had no response to the AAV. This is the antibody levels that were formed after treatment, and those group that did not have immune management had a very significant antibody response. And this, we believe, is the way we can improve safety and efficacy of AAV-mediated gene therapy when it's given systemically. So we studied this in mice. I'll go quickly through this part. We had the opportunity to give the mice 2 doses of AAV, which would normally not be allowed after the single exposure because of the immunization that occurs with the treatment. So in this scenario, we gave 2 doses of a drug that blocks the antibody response, and then gave an oral drug called rapamycin throughout the study. You can see that if you have never been exposed to GAA before, excipient or a control vector, or those GAA vectors where the immune modulation is given, there is no antibody response against GAA. Only when there's no immune modulation given do we see an antibody response against GAA. And then in terms of the capsid itself, again, same concept. Without the capsid, no response. And then in the 2 instances where the AAV is used and receive immune suppression, there is no antibody response, which we now know is a really important part of safety in systemic gene therapy. We took the same model to the canines with an immune management strategy that was developed for canines. You can see in the 5 animals that have been studied so far, they all restore GAA activity above the knockout animals or controls, and above the level that an unaffected dog would have. You see that in these 2 animals, very high levels of expression between 1 month and 3 months, and we're now just past the 6-month time point. So this correlates with the amount of vector that's given, and these are given intravenously, which is the goal to reach all the muscle cells and all the central nervous system. We took this same idea back to patients again. In this case, like the mouse study, the vector was given twice, first in one leg and then in the other leg, and the investigators didn't know which one it was. And we looked at the antibody response and found that in the 2 individuals enrolled thus far, they have no response, allowing them to get repeated doses of the AAV or over the lifespan go from low dose to high dose, for example, or maintain the level of expression. And that correlates with the amount of AAV that's in the blood after the dosing, that the immune suppression allows for greater exposure to the treatment. So the take home in all this is that aside from these studies, there are several studies progressing with liver-directed gene therapy in LOPD. We have a program with investigators at the NIH to study IOPD by the same gene therapy I've described. And the immune responses to the AAV are much like the anti-drug antibodies to ERT. And we have now a means to protect against those in patients. And that with this immune protection, we think this will enhance safety and efficacy, allow for repeat dosing, and most significantly in the IOPD population, to prevent immune responses to GAA itself when there's a severe or null mutation. So can't do any of this alone. This is our team at Florida, and I hope we have time for questions and just list them all here, as well as thanks to all patients and families who participated in these studies. So I think we have a bit of time for some questions. I hope we allowed enough time for questions and didn't go too fast.
We do have time for questions. We are yet to have anything pop through. So if anyone out there does have any questions, please feel free to pop them in the chat function. But otherwise, thank you very much, Dr. Byrne. That was great.
Great. We're really glad to keep this moving along, and hope we can help improve patient outcomes soon.
Beautiful. Okay, so I don't think there is any questions. So we will, hang on, we do have a question actually. So thank you for whoever submitted that one.
Relying on Allison to ask a question.
No, we've got one that's popped through the chat function saying, how far away is gene therapy? I'm sure you get this one a lot.
The study I just described is enrolling patients now. The systemic treatments in infants we anticipate early next year will continue, and then there's the later stage patients, or the LOPD patients that would receive the systemic therapy, will probably be in the next 12 to 18 months.
Beautiful. And we do have a question from Allison. Can I enroll?
We'll figure that out. Call me.
One other question, very similar to Allison. So how long would it be until you recruit from Australia or New Zealand?
Well, you know, the interesting thing about the Southern Hemisphere, and particularly the regulatory environment in Australia and New Zealand, is actually favorable towards gene therapy studies. And so it'll depend on the commercial sponsors that advance the studies from the US population to Europe and hopefully to Australia and New Zealand. But it actually, I think we hopefully will see an increasing number of studies in the region because the regulatory environment is actually quite favorable to bringing these kinds of therapies. And it's an interesting aspect of gene therapy. I maybe will comment when we consider the access to standard of care, which of course you have very readily in your part of the world, but in some parts of the world where there's not access to standard of care therapy that requires infusions and regular visits to the doctor's office, should emphasize that gene therapy approaches are intended to be very infrequent over the lifespan. In some circumstances, maybe once. In other circumstances with really early treatment, there might be 2 or 3 treatments over the entire lifespan. So when there's limited access to standard of care therapy, this very advanced therapeutic idea actually may have significant advantages, and it's just now incumbent on us to figure out how to make it affordable for all parts of the world. That I think has been one of the biggest challenges. A practical challenge, but one nonetheless.
Yeah.
Raymond has a question. If I'm on gene therapy, do I still need enzyme replacement therapy? So that's a very good question. The standard of care would likely be part of any IOPD study. And for adults, the original concept was to administer the gene therapy and then withdraw the enzyme replacement therapy. The first study was done on a specified interval, something called a registration study, or one that would lead to marketing approval, would probably have to do that in a randomized fashion, and that's blinded. So some patients would remain on ERT and some would discontinue. And then either through biopsies or imaging or both, as well as the time function test, one could then determine, without the patient knowing whether they're receiving ERT or not, whether the gene therapy treatment was effective independently of the ERT. So that's what's contemplated for those studies. And until as you've seen, the development of the other protein therapeutics takes many years. So when you think about the slow nature of LOPD progression, it would probably take 2 to 3 years to conduct such a study once it begins. So the answer won't be forthcoming immediately, but this can be addressed in the study design I was referring to. And then once there's evidence that the gene therapy could act independently, then in theory, patients who are newly diagnosed, or if there's marketing approval for the treatment, it would potentially be given alone. And this has happened in SMA. I described the treatment paradigm for Zolgensma. Now with newborn screening, Zolgensma is the prominent choice among families for their children with SMA, because the alternative, Spinraza, requires up to 4 lumbar punctures per year and general anesthesia to administer. So the burden of treatment is quite high. It's not as challenging, obviously, as going twice weekly for enzyme infusions, but it still is something that parents choose to avoid, and if they can, and receive the gene therapy treatment. But now there's a consideration of whether there'd be an advantage to having both, or a third medication that's now available called risdiplam seems very promising to combine with gene therapy. So it's very reasonable to think that although the studies may withdraw enzyme replacement therapy for a period of time, there may be advantages to focusing on the neural components through the gene therapy and the peripheral muscle components with the next generation gene therapies that are anticipated to have a greater impact. And we might see that their impact is even amplified when there is a nerve cell functioning normally to work with a muscle cell that has received enzyme replacement therapy, as opposed to trying to go it alone with diminished influence of the nerve function. So combination therapies are a very reasonable consideration.
Thank you. We do have a couple more that have popped through, so I'll just go in order that they've appeared.
Being shy.
So the first one we've got through says, "Thank you, Dr. Barry. Great presentation. Can you please tell how is gene therapy administered into the spinal cord?"
So In a study we're initiating in Friedreich's ataxia, the gene therapy will be given actually by two routes. It's given into the peripheral vein like ERT is, and then in order to augment the amount of expression in the brain, because there are balance and movement problems in Friedreich's ataxia, at the same time, a dose will be given into the lumbar spine like Spinraza is used, but only one time in a lifetime for the FA or even for the Pompe therapy. And so it's given in the same way as to access with the needle in the lumbar spine, and then a slow infusion of the vector is given there in combination. It's not yet determined whether that will be that same dual route of administration will be beneficial in Pompe. This is one of the things we're investigating in the canine model. The spinal fluid administration alone was not as effective in that model as the treatment in peripherally, where the muscle is also expressing alpha glucosidase. In the new rat model, we'll be able to test one or the other or the combination therapy, and that's anticipated to be done over the next 6 months. And then we'll know more whether it would be only an infusion or an infusion plus the spinal fluid administration. But very good question.
Definitely. Another one, you talked about gene therapy targeting the nerves too. Is this an aspect that ERT doesn't target?
Very good question also to re-emphasize that. We know that ERT is a very large molecule and does not cross the blood-brain barrier. And in some, and really because there are not cognitive problems in Pompe, this was really why it was considered one of the favorable choices for enzyme replacement therapy, focusing on the peripheral manifestations. I think in very early on, we didn't fully understand the contribution of some parts of the nervous system. It's really principally the motor nerves, which are just a small portion of the overall central nervous system. But the ERT does not have a way to get across the blood-brain barrier. And this conceptually can be approached by different ways, one that I described. And then in some cases, blood cells that pick up some enzyme in the peripheral circulation can cross into the brain, where they form some of the supportive network of the brain tissue, and then bring with them the enzyme to help influence the brain structure, the alpha glucosidase in the brain. So these are depending on the efficiency of the two mechanisms, we'll see what influences the magnitude of the effect. So it is possible that very high levels in blood cells, particularly if there is the type of therapy that AvroBio is pursuing, could bring alpha glucosidase into the brain, or when it's significantly overexpressed in the periphery, like the study that Spark is doing, there's some evidence that some of the material can cross with the help of the leukocytes or white blood cells.
And another one, it sounds like we have quite a few eager study participants among us today. Another one about study. Is it best to get in for the study or wait until there is more data? And do you only get one chance at gene therapy?
Very good, also a very good question. We will conduct to my knowledge, we're the only group that has initiated studies with the intent to allow patients to receive multiple exposures of AAV over the lifetime. The conventional wisdom is that it's a one-time therapy. If the immune treatment is given before the gene therapy, it allows it to be re-administered. So that was one of the points I wanted to make. So, and that's important for early participants in gene therapy studies, because it allows for them to also, at some point in the course of the study, receive the most effective dose. So another study design we're contemplating is in which patients who received the low dose therapy would at some point cross over into the high dose therapy. And this has never been done before in a gene therapy study. All participants usually only receive one exposure. But by protecting the immune responses, the notion of dose escalation can be tried. And that has some advantages in terms of getting the greatest effect in a small number of people, because it's not known to the participant whether they're in the low dose or the high dose therapy. So this increases the significance of the clinical findings when it's not known to them which dose group they're in. So, we want to make sure that even the early participants in studies have access to the most effective therapy, and that particularly in the case of IOPD, where growth might impact the potency of the ultimate treatment, that they would, over the lifespan, be able to receive multiple doses. Not the frequency of ERT by any means. We're considering it's probably 3 times over the lifespan is what would maintain the level of expression at a point that would allow really to reach that level or above that of a carrier, of an unaffected carrier patient, is the goal.
Thank you. I think that is all of our questions at the moment. Hang on, no, Alison. Would gene therapy help restore some muscle?
So, muscle responds to training that is signaled through the nerve. And if the nerve cells who are not functioning well regain some of their function, and they have the ability to branch out and contact other muscle cells, theoretically, then there would be a greater response to exercise. And that's, I think, maybe what you're referring to in terms of restore. If there's sufficient early muscle progenitors that would respond to exercise, then theoretically that could influence muscle mass and therefore strength. We do know now that exercise is critically important, both for breathing function and for all of our activities. So anything that would optimize the response of the muscle to a functioning nerve would be valuable.
Thank you. I think it's always very exciting to talk about new potential therapies. So nice that everyone's got a few questions there. I think that was our last one. Last call for any questions.
Last call. We're not even at the pub yet. Well, thank you so much for all your attention, and hope to be able to visit in person next time and be 3D instead of 2D.
Yes, thank you so much. That was really, really great. And yeah, hopefully next time we are in person.